Okay, guys, I'm back to record Module 15. This is nursing care of patients with mood and affect disorders. Our learning outcomes are explain the causes, describe therapeutic measures, risk factors, and pathophysiology, and plan nursing care of clients with depressive disorders and bipolar disorders. Mood disorders, also called affective disorders, are disorders in which the major symptom is extreme changes in mood and emotions, mood, which is emotions, and affect, the outward expression of mood. Moods involving both highs and lows are bipolar disorders. Low moods without highs are described as depressive disorders. These disorders are diagnosed when symptoms begin to interfere with normal daily functioning. It affects all age groups, socioeconomic, and ethnic groups. We're going to look at major depression first. It's an episodic condition. Symptoms interfere with the person's usual social or occupational function. Depressed people view the world through gray-tinted glasses. The DSM-5, which is the Diagnostic Manual for Mental Health Disorders, specifies that symptoms of major depression include either a depressed mood or anhedonia, and that word is ANHEDONIA, which is loss of pleasure in things that are usually pleasurable. Signs and symptoms are above on your PowerPoint. We have weight loss or gain, change in appetite, sleep disturbances, fatigue, agitation, psychomotor retardation, decreased ability to think, remember, or concentrate, feelings of guilt or hopelessness, indecisiveness, and suicidal ideation. With bipolar disorder, it was formerly called manic depression or manic depressive illness. It is a mood disorder in which patients experience the mood states of both mania, which is extreme elation or agitation, to extreme depression. Bipolar is more severe than major depression. These patients stay depressed longer, they relapse more often, they display more depressive symptoms, they have more delusions and hallucinations, they commit suicide more often, require more hospitalization, and overall experience more incapacitations. Their moods can cycle slowly over weeks, months, or even years, or they can be rapid cyclers. These moods can change several times in an hour. On the previous slide are the symptoms of depression, and that goes along with bipolar depression as well. Above on this slide, we have the symptoms of mania. Euphoric moods, increased energy, restlessness, decreased sleep. These patients tend to get very little sleep, and that in turn is like a cycle that causes them to be even more manic. Grandiosity, when you look grandiosity up, you will see where people tend to talk about themselves in a grandiose manner. I'm going to be the President of the United States in the next election. And it can go from mild grandiosity, where they're talking about things that probably are not going to happen, to those things that you know are not going to happen for sure. Irritability is another symptom. Distractibility, they can't concentrate. Poor judgment. Rapid speech. Another term you might hear is pressured speech. Flight of ideas, they can't concentrate on one or focus on one topic at a time. They're talking about going to the grocery store, then they're talking about something going on at home, they're talking about something going on at work, and they're just bouncing around from topic to topic. And they're not interrelated topics. Goal-directed behavior, delusions, focus on pleasurable activities, intrusive or provocative behavior. Etiologies, usually, according to the psychoanalytic theory, they believe that anyone who's suffered a loss are at risk for depression. It can also be attributed to unresolved anger turned inward. The biological theories offer genetic links and neurotransmitter dysfunction. Serotonin, norepinephrine, and dopamine all have an effect on our moods. If these are elevated, then the mood is elevated. If they're low, then the mood is low. And some also believe that there's a link between these neurotransmitters and female hormones. I personally believe that female hormones have a lot to do with mood because I'm one who has been affected by that all those years with premenstrual syndrome. Let's look at different diagnoses on page 1365. With differential diagnosis, the symptoms of depression, according to your book, may occur in conjunction with other disorders, such as schizophrenia. It could be drug side effects or drug overuse, heart failure, nutritional deficiencies, drug toxicity, thyroid disease, fluid electrolyte imbalances, infections, and diabetes. All of these can be associated with depression. Many times it is a thyroid issue, a hypothyroidism or hyperthyroidism issue if we look at mania. So that needs to be ruled out among these other things before a diagnosis of depression. And it could be that they are depressed, but they have these other comorbidities or other things that go along with that, so that if you correct the underlying cause, you correct the depression. Therapeutic interventions, page 1359 through 1363, we have medications for mental health alterations, antidepressants. About 80% of people with major depression do respond to treatment, but bipolar depression is more difficult to treat. The list of medications for all of the mood disorders are on these pages. Lithium was once the drug of choice for bipolar treatment, but it is an anti-manic and has a very narrow therapeutic range, which means that toxic levels can develop easily. They need frequent blood level tests to be sure they are in the therapeutic range and not too much or too little. They need to be in the therapeutic range for it to do its job. Mood stabilizers like anticonvulsants, Depakote is one, Lamictal is another. These are commonly used now more than lithium. These must be monitored closely as well, since they can induce a manic episode. These also have levels. A summary of the meds again is from page 1359 to 1363. Nutrition notes, 1366. Table 54-7, summary of depression, and see the nursing care plan for mood disorders and interventions. And also there's a critical thinking exercise, Mr. Zen's, on page 1366. Back to the slide, psychotherapy. That's where you see a psychiatrist, and they may use different things to help with the depression or the mania. ECT, electroconvulsive therapy, may be used, and then mood stabilizers when there is bipolar. Risk for suicide, back on page 1367, the care plan talks about depression there and a risk for suicide. We need to become comfortable to ask directly about suicidal ideation, initiate suicide precautions as needed, create safe environments, and encourage the patient to seek help. On 1377, there is a focus on the older adult and mental illness. Please read that. The section on depression and suicide in the older adult will be discussed here. Depression in an older adult should not be viewed as a normal part of aging. It should be diagnosed and treated. Think about what older adults have to deal with. Physical and mental decline, loss of a partner, loss of friends, loss of function, isolation. They may have to leave their home and go to assisted living or to a nursing care facility or to a family member's home. All of these may lead to depression, and depression can be expressed in physical ways like pain. If the depression is not noticed and treated, it can lead to suicide. There is an especially high rate of suicide in white men over the age of 75. If older adults express hopelessness or a desire to die, this must be taken seriously and followed up on. See the comment on page 1377. Living is harder than dying ever could be. And that's in quotes. I am a used up old man who is a burden for everyone. I am useless. I can't do anything anymore. I don't know why God won't take me. If any of these are expressed, certainly a suicide assessment should be done. The physician should be notified, and there are also questions here too. Immediate referral for psychological evaluation is needed, and if there is a plan to end one's life, if they actually have a plan, then resources are available. Never leave a suicide client alone. They need around-the-clock supervision, and their environment must be cleared of anything that may help them with their dying wish. Phone cords, shoelaces, call-light cords, medications at the bedside, weapons of any kind, razors, jewelry, pens, mirrors, all of these things. If they are on a psych unit or a psych ward, none of these things are allowed. Hospital admission is often appropriate with the higher risk clients. Those that they don't feel can be managed on an outpatient basis would need to be hospitalized. Encourage the client to talk and reminisce. That may help. Develop a do not harm contract with the client. Try to prevent the social withdrawal and isolation that can occur. Family members can help with visiting. Senior center might be helpful to get them out, and maybe they won't be as lonely. Exercise increases our happy neurotransmitters. Volunteering and other things, all of these things can help with loneliness and decrease their chance of becoming depressed. Okay, again on page 1377, there's a focus on the older adult. Ask directly about suicidal ideation. Initiate suicide precautions as needed. I just went over this one. Sorry, guys. It's not wanting to move for me. There we go. Okay. Nursing diagnosis, ineffective coping. Use therapeutic communication. Allow patients to verbalize feelings. Ask them to describe stressors and identify coping mechanisms. Help patients set goals and encourage participation in care. Review communication techniques, which are found on page 1349, and 1350 has communication blocks. These are things you learned in 101, and this is a very good review. Powerlessness. This we want to assess for powerless feelings. Help the patient identify uncontrollable or controllable factors. Allow them to vent their feelings. Encourage active participation in goal-directed activities. This is a video, Living with Depression. I have not checked to see if it's still working, but I hope you're able to click on that. Otherwise, go to YouTube and you could search and see if you can bring up this video. Okay, one review question, the answer is 2. The next one, the answer is 1. Thank you.